in the course, and this is the talk on malignant tumors. And I'm going to spend almost all of the talk looking at metastatic brain tumors because, as you know, metastatic brain tumors are very much more common than primary malignant brain tumors, and radiosurgery has a questionable role in the treatment of primary malignant brain tumors. Greg Murad and I have written a chapter for Yeoman's on the use of radiosurgery for malignant brain tumors. We've reviewed the literature. The chapter is available for you on the Moodle site. But you'll see that most of the reports are small case series. And the only definitive work, and it's not, I wouldn't call it definitive, but it was a class 1 randomized study, showed that radiosurgical boost was not helpful for malignant gliomas, but there were some methodological problems. So I'll be happy to answer questions about malignant gliomas, but most of the data and most of the activity concerns metastatic brain tumors. So, as you know, metastatic brain tumors, that's where the patients are. You know, if you're a brain tumor surgeon, there are approximately 200,000 metastatic brain tumors identified every year, and there are about 20,000 primary brain tumors identified, about half of which are malignant. So they outnumber primary brain tumors 10 to 1, malignant primary tumors 20 to 1. Almost half of cancer patients will develop a brain met during the course of their disease. That number is going up because cancer patients live longer with their primary disease, and the longer they live, the more likely they are to develop metastases. 60 to 70% are multiple brain mets, the remainder are solitary mets. So when we're taking care of brain tumors, we really have two goals. Goal number one is survival, and that goal is fairly easy to measure because almost everybody who lives in the United States has a Social Security number, and when you die, your family gets death benefits, and so Social Security does a pretty good job of keeping track of who's alive and who isn't. The second goal is to preserve or improve quality of life, and that is much harder to measure. There are validated instruments for quality of life, the SF-12, the SF-36. There are some instruments that are specifically designed for brain tumor patients, but they're difficult methodologically to administer in a reproducible manner, especially with a patient population like ours, where patients tend to come from a long way off to get a treatment, usually surgery or radiosurgery, sometimes chemotherapy, radiation therapy, and then they go home. And you try to keep track of them, but they move, their phones get disconnected, they get distracted by a lot of major life events, and they may or may not be interested in filling out your quality of life forms as their disease goes on. So instead of doing that, in many patients, we try to keep track of their CAT scans and their MR scans. They're usually a little bit more willing to do that, and so we're making the assumption that radiographic control of their tumor equates to preservation of quality of life. And that is a very crude assumption because side effects from medication, intercurrent illnesses, and a host of other problems are not going to show up on a CAT scan or an MR scan. And so their quality of life could be getting much better or much worse while their disease stays the same on the scan. Now, in terms of metastatic brain tumors in particular, no intervention survival is very short. We know that corticosteroids are helpful. It can usually dramatically helpful because they reduce the edema around these tumors for about a month, and then they start to become less effective. I would just caution you, and you don't see this because you're mainly involved in the acute care of brain tumor patients, but chronic corticosteroid therapy is horrible in terms of side effects. And we see many patients, usually not our patients, who have been on steroids for months and months, and they are Cushingoid, they are prone to illness, they have stria, they have bruising, they have diabetes, they have myopathy that makes it difficult for them to get up and get around, and their overall quality of life is poor because of the steroids. So steroids are great, but as best you possibly can, you should use them short term and try not to use them in the long term. Whole brain RT, we're going to look at some studies, but the studies going back to the 1950s that were run by the Radiation Therapy Oncology Group, RTOG, definitively showed that for the average patient with a brain met, survival would be increased. With whole brain RT, there were a number of different dosing protocols used, and for a variety of reasons, the standard dosing protocol, again, this was part of a prospective randomized study. The standard dosing protocol is 10 fractions, 300 gray to the whole brain per fraction, so a total dose of 3,000 centigray. Sometimes you'll see the fractionation extended to 12. Anything beyond that is really an attempt to game the billing system and doesn't have any relationship to any potential benefit to the patient. Surgery, we'll show you some data on surgery, but Patchell and others pretty definitively showed in fairly small series, but well-conducted series, that surgery added to whole brain RT was better than whole brain RT alone. And then there are a lot of studies on stereotactic radiosurgery. Most of them are retrospective series, but some of them are prospective class 1 studies. So, this is a very familiar scenario to all of you. A man with a smoking habit presents with headache, and in this case visual disturbance. Neurological exam shows a neurologic deficit. The workup reveals multiple lesions. So we've got 2 lesions in this hemisphere. We've got a lesion here, and so we know from the imaging and from the history that these are very, very likely to be metastatic lesions. We do not have a tissue diagnosis, however. So we can't just jump in and make the assumption that it's cancer. We have to get some tissue, and so we're going to operate on the largest lesion, probably in this position, and I don't know if this will play, probably not. But you're all familiar with the surgery. So the pathology, poorly differentiated carcinoma, with appropriate immunohistochemistry to verify that the primary is most likely. And then we move on, maybe to treat the small lesion in the other hemisphere with radiosurgery. You've seen this protocol multiple times now, but today is radiosurgery day, so we were downstairs putting head rings on under local anesthesia. Everybody gets a CAT scan. Yesterday they got an MR scan. We then do the dose planning, the goal, conformality, secondary goal, steep dose gradient, and we use sphere pattern here. Here, for example, a petroclival meningioma with a multi-isocenter plan. The red line is the 70% isodose line. That's the isodose line that we use with multiple isocenters because it gives us the steepest dose gradient. We use the 80% line with single isocenters because that gives us the steepest dose gradient. Patients wait, and one at a time they're connected to the machine. It takes about 10 minutes per isocenter, so the total treatment time is directly proportional to the number of isocenters, which relates to the degree to which the lesion departs from spherical shape. So here is a brain met that we could operate on. I guess we could go through the trigeminal nerve entry zone and try to take that out, but it's in the pons. It's not a great spot for surgery. And this happens to be one of our long-term survivors. This is a 5-year post-treatment MR scan. Now, we don't have a lot of 5-year survivors of metastatic brain tumors. I'll show you the data. We're sort of updating our long-term survivors as defined by 4 years survival. One of our medical students and I are doing that, but there is a tail to the survival curve, and some of these people will be truly cured. This is the machine that we're using today, the Trilogy machine. Our current commercial partner is Vera. So this is this talk again is on Moodle if you need the bibliography, but this is a summary of the biggest series in the literature, reviews of radiosurgery for metastatic brain tumors. And again, the moral of the story is centers that are doing a lot of anything tend to produce the same results. And so if you just go down the chart, you see that the local control is in the 80s for most of these. 1 year survival for most of them is in the 30 to 40% range. Median survivals tend to be in the same range. And you'll notice that the largest linear accelerator series and the second largest total series in the literature is from the University of Florida. We'll talk about in a few minutes. All right, so let's go through the class 1 evidence that pertains to the treatment of metastatic brain tumors. It all starts with Roy Patchell. Roy was at the University of Kentucky when he did most of these studies, but I think he's moved somewhere else, Aaron. Do you know where he is now? Yeah, okay, that's right. Yeah, he's at Barrows now as the chairman of neurology at Barrows. Yeah. He interviewed for chairmanship here, but, well, I won't tell you about it because it's being recorded. I'll tell you later. In any case, Patchell and his group did a study. It was a small group of patients, 48 patients, and they looked at surgery plus whole brain RT, and this should be versus whole brain RT alone, not surgery alone. And the survival in the surgery plus whole brain RT group was 40 weeks versus 15 weeks. Recurrence was 20% versus 52%, and independence 38 weeks versus 8 weeks. So there was a very striking improvement in all of these measures once surgery was combined with whole brain T. In 1998, the same group did a study of 95 patients where they looked at surgery plus whole brain RT versus surgery alone. And the survival was not different in the two groups, but recurrence was, not surprisingly, more common with surgery alone, and neurologic death was much more common. So the moral of the story here is that you can cure some of these tumors with surgery alone, and I think that's not the moral that they drew from the study, the conclusion, but that definitely was shown. It's just that you'll have a reduced recurrence rate if you add some kind of radiation to the surgery. So then we have some class 1 studies that involved radiosurgery, surgery, and whole brain RT. And this study was an RTOG study run by David Andrews and others, 331 patients. There was a survival advantage, and you'll note that the survival is short for single metastases only. Local control was not statistically different between the two groups, and in a post hoc analysis, the radiosurgery group was most likely to have stable or improved Karnofsky and less likely to be steroid dependent. So it showed a slight advantage to adding radiosurgery for 1 MET. Now, Kanzioka did and his group, a short study. It was terminated early because of a futility analysis, and basically they looked at the same question, whole brain RT versus whole brain RT plus radiosurgery, and the survival was not statistically different. The survivals aren't likely to vary much because the survival is usually driven by the status of the systemic disease. But local control was 0 in the whole brain RT group and 92% in the whole brain RT plus radiosurgery group, so the trial had to be stopped. Well, Yama, a Japanese study, 132 patients, again, survival not different, and this one is whole brain RT plus radiosurgery versus radiosurgery alone. The local control was better with the addition of whole brain RT. Regional control was better, and there was no difference in a fairly crude analysis of neurologic status. Now, this should not surprise you. So if you add whole brain RT, you're adding total dose, and you should get better local control and better regional control. There are ongoing studies. I think there have been some preliminary results, but no final report from the NCCTG study, which will randomize patients and do a much more detailed quality of life and neurocognition study. And then there's an EORTC study that will randomize to surgical resection versus non-surgical resection. And then we'll look within the two groups at radiosurgery plus whole brain RT versus radiosurgery alone. And then finally, there is one study from 2008 where surgery plus whole brain RT, the Patchell standard, was compared to radiosurgery alone, and there was no difference in local control, there was no difference in survival, and regional control, as you would suspect, was better with whole brain RT. So that's the class 1 that we've got. Now, just to look at our study, and this would be typical of the big retrospective studies that have been published, we did a chart review. This was a massive project because we had to extract a lot of data. And I'm not going to go through each one of these, but when we used the Social Security Death Index to determine survival. And this is a breakdown of the patient characteristics. Now, in this study, there were 619 patients, and there were 1,569 metastatic brain tumors that were treated. Some of the patients were treated more than once. And the median age was 60, the median Karnofsky was 80, and you can see the breakdown by sex, RPA, tumor type, primary tumor controlled or uncontrolled, whether they had systemic metastatic disease, whether the metastasis presented at the same time as the primary or later, the number of lesions, the lesions that were in eloquent brain versus non-eloquent brain, whether they had whole brain RT, whether they had surgery, and the number of radiosurgery treatments. The RPA is the recursive partitioning analysis. It's for metastatic tumors. It's a 3-class analysis from the RTOG. And basically, as a result of all of their studies of whole brain RT, for metastatic tumors, they can statistically go back and they can tell you that if a patient has a Karnofsky less than 70, they're going to do poorly. And so that's class 3. If a patient has a Karnofsky greater than 70, no systemic disease, and controlled primary, they're going to do well. That's class 1, and everybody else is in class 2. So if you're trying to eliminate selection bias, which is the bugaboo of all retrospective studies, the RPA can be somewhat helpful, but not perfect. All right, and so 90 patients underwent multiple treatments, and these are the treatment characteristics of the 1750 centigrade was the dose. The magic dose for a MET is 2,000. We try to give 2,000 whenever we think we can get away with it. Median dose volume was 4.6 cc's. Remember, radiosurgery, you think in volume, not diameter. The median number of lesions was 1. But you'll see that we treated 1 all the way up to 20 lesions. And you can argue about whether that's advisable or not. Certainly, we have no hesitation treating 5, 6 lesions with radiosurgery. Above that, we're usually going to be thinking about whole brain RT. So we're mainly interested in what we would call oligometastatic disease. Okay, so this actually turns out to be the wrong slideshow that we've got loaded here, Frank. But, yeah. Well, maybe. Let's take a look, because I think the graphs are important.